The biggest source of failure in paramedicine comes from the fact that our patients do not look like our mannequins. Nearly 50% of the male population have facial hair, whilst our mannequins are still like this. Does it really matter? Yes, because you cannot ventilate a bearded patient like the one who is shaved. So in this video I will show you the most effective techniques for proper management of the bearded airway. My name is Alex Hepner and this is Group Call. Whilst the idea of mechanical ventilation was born in the 17th century, the first proper medical publications regarding airway management in bearded patients can be found in 2005. For the last 18 years we know that the facial hair is an independent predictor of impossible BVM ventilation, and we still teach our clinicians to ventilate shaved mannequins, sending them to fail in field. Are we doomed? Yes. No. There are things you can do. The first one is ventilation through nose with use of a newborn mask, suggested by Dr. Rao and his team. The mask extends from the bridge of the nose to the maxillary alveolar ridge. The mask is grasped in the conventional manner and with the mouth held closed to prevent air from leaking during positive pressure. Ventilation is totally accomplished through the nostrils. I like this technique as it can be complemented with an NPA, which is a well-tolerated yet effective airway adjunct. The second technique is called open mouth ventilation and is commonly used in edentulous patients, but also works on those with excessive facial hair. Described in 2008 by Dr. Racine, is a really interesting one for those responders who have very basic equipment. The caudal end of the mask needs to be positioned just above the lower lip, while maintaining the head in extension. The third technique seems to be the most effective one, however require additional elements. In this case is gel. Originally, authors of this method covered the edge of the mask with 5 mm of ultrasonography gel, but effectively it can be gel used for lubrication of an eye-gel or ET tube. This method seems to pose two challenges though. In case of excessive ventilation with a positive pressure, some particles of the gel may be sprinkled into your patient's eyes. The other thing is that the mask will be very slippery, or greasy if you like, therefore keeping it on the patient's face in a moving ambulance may be quite challenging. Now I need to make a disclaimer here. There is a technique I don't support, a controversial one, but it's described in literature and, as far as I know, was quite popular in some parts of the world, Australia. Therefore, I need to mention it. It's putting a defibrillator pad with a hole cut in it between the patient's mouth and BVM mask. As I said, I deem this method controversial and don't think we should be using it due to the risk of potential iatrogenic obstruction of the airway. But it's only me. What about trimming or shaving patient's beard? This technique is time-consuming, not effective, and can lead to iatrogenic obstruction of an airway. Not even mentioning that some cultures like Islam, Judaism, Amish, beard is something more than just facial hair. So, however tempting, I wouldn't do it. What I would do though is I would check this video with some good ventilation tips. My name is Alex Hepner and this was Group Call.